to this webinar that we are hosting between Second Opinion and Personify Health, and we have an incredible panel here today. I'm going to let them introduce themselves, but first I will say hello. I am Chrissy Farr. I run Second Opinion, and I am fascinated, have long been fascinated with this question of what employers are planning to do in the face of rising costs that we see year after year. To me, this is the pressing and most important issue that we face today in the employer landscape, and it really is not discussed enough. And I think it will lead to some very big changes in the near future. So with that, I'm going to introduce this incredible panel, or rather let them introduce themselves. And I've told them, 10 seconds for a quick bio. We'll start with Ellen, and then throw it over to Vin, Chris, followed by John. Ellen, you're up.
Wonderful. Thanks so much for having me on this panel today. My name is Kelsay. I am the president and CEO of an organization by the name of Business Group on Health. And we are the largest and longest standing association working with employer plan sponsors or employer purchasers on a variety of healthcare and well-being related needs. So excited to explore the topic with all of you on the panel today.
Hi, everybody. My name is Vin Gupta. I'm a pulmonologist out here in Seattle. Practice part of my time. The other part of my time, I work in health innovation. Actually, I'm delighted to call Chrissy a colleague and a friend at Manatt. It's good to work with a lot of different clients there focused on early stage diagnostics all the way to any range of matters in generative AI. So great to be here.
Hi, Chrissy. I'm Chris Michalak. I'm the executive chairman for Personify Health, former CEO of the company, also the former CEO of Virgin Pulse. We're the leading well-being provider. We're the largest independent TPA in the country. So we're helping employers every day solve healthcare costs that they're having and helping their members to engage in their healthcare every day. So look forward to the panel.
I guess I'm rounding it out. I'm John Slotkin. I'm Chief Medical Officer at Contigo Health. Working with some of the nation's largest and most innovative employers. Really pleased to be here. Thank you.
So we've got a stellar panel, and I'm going to kick things off with Ellen, because very recently your company, the Business Group on Health, put out one of its reports looking at really data across the landscape of what employers are facing. And these reports, by the way, if you don't read them, they're an absolute must read. So Ellen, I'm going to just give you a little bit of spotlight to talk about what you learned and specifically related to costs. What are employers seeing today? And can you give us some context around the numbers?
Yeah, for sure. Thanks for that opportunity. We have been fielding our employer healthcare strategy survey for a couple decades now. We survey on a range of topics: healthcare strategies, healthcare cost, employer considerations for the future, reactions to things that are happening in the marketplace. And this year, one of the top line findings coming out of the survey is that healthcare costs are expected to achieve an all-time high in 2026. For many, many years, we've been talking about healthcare cost escalation, showing no sign of abating. And for 2026, we are seeing anticipated healthcare trend coming in at 9%. That is a 62% compounded increase since the year 2017. We are also seeing that for the second year in a row, actual healthcare costs have surpassed employer expectations, which we had not seen prior to last year and now again this year. Within that, there are many drivers of healthcare costs. Certainly, we've got some underlying delivery system friction in need of transformation. We see increased utilization of services, unit cost concerns. Certainly, pharmaceuticals are a growing proportion of overall healthcare cost. Pharmaceuticals now account for 24% of overall healthcare spend. Within that, GLP-1s are certainly a more recent phenomenon that is driving that. And then just an increased prevalence of chronic conditions within the population, whether it be musculoskeletal, diabetes, cardiovascular, as well as rising rates of cancers and rising utilization of behavioral health services. So lots of reasons for that trend, and then future cause for concern beyond 2026, which we'll probably talk about later in this discussion as well.
Vin, I would actually love your reactions to that, especially given that prior to being at Manatt, you actually were the chief medical officer of Amazon's pharmacy business. So, what is it? How do you kind of react when you hear that 24% specialty medication spend number that Ellen cited? And is there what can employers kind of do to combat that?
I was blown away, Chrissy. I mean, Ellen, I learned a lot just in those few minutes here, sharing those facts and figures. I think it's surprising to me, just having worked for the second largest employer, their benefits team, and all the struggles that they face, which I'm sure are emblematic of what other large employers, self-insured employers are facing across the country, Chrissy. But I mean, the numbers speak for themselves, especially given that we have new tools in our toolkit as clinicians to care for patients, but these tools are expensive. And what we struggle with at Amazon, I was there for almost 6 years. We would always want to wet test new ideas across our direct-to-consumer businesses internally with sort of dog fooding Amazon employees to the extent that our benefits team was open to that. But even when we tried to do that, there was always concerns about utilization. And Amazon health benefits are stellar, but upwards of 45% of Amazonians, again, this nation's second largest employer, never signed up once for preventive care. Whether it's a primary care appointment, a basic screening, you name it. We could give them an amazing list of vendors to choose from, make sure that they know about open enrollment and send mailers, all the things. That wouldn't really change that. And so when I hear Ellen's kind of where are we headed? Where are we now? Where are we headed? When I think about all these new incredible tools and therapeutics that are available to us, I do then think back about the struggles of a large self-insured employer and how do we get employees to do what we want them to do, which is engage early and as often as needed in preventive healthcare. So perhaps they don't need a GLP, or if they do, it's time limited and we can wean them off to maybe something less expensive like an oral. But these are challenges that are not new. I think they're only going to get worse.
Ben, just to double click on that, it's what you just shared about the lack of prevention is harrowing, and I've consistently heard that it's gotten worse since the pandemic, and employers are really struggling, especially in more remote or hybrid offices. So, have you seen anything work to get that utilization going when it comes to all the things that will ultimately bring down cost? And what does that look like in terms of just ROI for self-insured employers, especially with more people just bouncing around between different companies every few years, which is now, the norm. Didn't used to be, but it is now.
Yeah, I think you bring up a great point, Chrissy, especially that last point, which was there's an understandable reticence to want to cover something expensive like an injectable GLP if you're, say, a large employer like Amazon, because you don't know if your workforce, most of which is transient, will stay with you, and will you, as the company, benefit from productivity gains because you have a healthier workforce. That is a very difficult challenge to reconcile. What I've seen work at scale, I think I have not seen any great examples of a large self-insured employer cracking the prevention code quite yet. I think there's on the margin. I'm sure Ellen and everybody else on this distinguished panel might be able to cite better examples on the large self-insured employer side. I am optimistic, though, that what I think ails prevention is the fact that we do not have diagnostics to meet this moment where people are wanting more healthcare at home. We have great tele-triage at home. I'm biased, we have great pharmacy options that are mail order now at home that didn't exist even 3 years ago. What we don't have, Chrissy, is an easy, frictionless way for people to diagnose themselves with disease, to screen themselves. It's still very frictionful, whether it's a low-dose CT scan for lung cancer, leading cancer-related cause of death in the United States. 11% of people utilize that scan. It's a 90% do not for something that could extend their life. We can go on and on across the spectrum. 60 million people don't know they have stage 2 hypertension. The problem here, in my view, is largely driven by the fact that people have undiagnosed illness and don't have an easy, frictionless way to understand that. But we have better ways to engage in tele-triage and in pharmacy. We just don't have great up-funnel ways to bring them into the healthcare system. I'll lastly just say, my experience at Amazon, really reinforced this. If people, especially the sandwich generation, 35 to 54 years of age, they're busy, older parents, children, busy work lives. If they don't want to be a patient, and they don't feel acutely unwell, like they have the flu or something like, on that spectrum, they're probably not going to want to be a patient. Meaning we have to find a way to tell them that, hey, maybe there's something wrong that you need to get checked up versus just encouraging them to see their primary care doctor. And so I do think it's a problem of diagnostics to meet this moment.
Yeah, and Chris, I mean, you and I have talked a lot about point solution fatigue because when I hear Vin speak and I hear Ellen share the statistics that she shared, I'm thinking, one, all these point solutions brought into employers in theory to solve these problems. You have point solutions for obesity, for cardiovascular disease. A lot of them incorporate some aspect of diagnostics, and they all claim, or most of them claim, that they can bend the cost curve. It's been, 15 years since a lot of these point solutions entered the marketplace. What is going on, Chris, that we're seeing this disconnect, where, maybe some of these claims and promises are not leading to a much better trajectory for employers, or would things have been even worse, had these point solutions not come along? I'm curious for your take on just that aspect of what employers are now facing today.
Yeah, I want to just leap off a couple of Vin's comments. I think prevention is fundamentally rooted in engagement and acumen. Do I know what I need to do? And am I engaged around my healthcare? We see that as the kind of the root of really good prevention. And if people are really rooted in engagement, they will go out and find the solutions that best meet their specialty need. And I think if you look at employee surveys, they want solutions that meet their specific healthcare needs. So they want those to be available. Their engagement in them is the challenge. And we think it's important to get people engaged in their healthcare each and every day. That's the heart of prevention. Now, those specialty solutions, some of them in any given year are winning and other ones are waning. And we see that across our base. So we have 75 specialty partners in our ecosystem solution, and some are doing very well. Mental health continues to be very strong. Women's health continues to be very strong, and there continues to be strength in the chronic care conditions. I think weight management, given everything going on with GLP-1, has really taken hold in some organizations, and they're actually looking to manage the cost of those folks who are participating in those programs. So I think specialty care and specialty solutions have a real role to play. Now, the thing that employers are really looking at in an environment like Ellen just described is they're looking, are these solutions making a difference? Are they actually reducing costs? Are they actually leading to better outcomes? And I think that is the challenge for every specialty solution that's in the market today. Can you prove that the thing that you're doing to help the employee is actually leading to better outcomes? And I think that's the challenge for all specialties.
Yeah, so John, to that point, I mean, if I look at point solutions today, like I think MSK is an incredible condition that makes so much sense for these employers because it's a top cost driver. And if you can get somebody to away from an expensive surgery that they don't need and towards a much lower cost intervention that works, which in theory is, PT, and that can be, I could see huge potential for AI. I just think MSK is kind of like the pinnacle of what we see in the point solution landscape, and you can see real ROI with MSK, and I think that was borne out in a lot of the work that the Peterson Health Technology Institute has done. So you come from that background. MSK, clinically is your world. Curious for your thoughts on, do you agree with me that kind of MSK is really the kind of, area to be in if you're a point solution business for many of these reasons? And curious if you think that that kind of ROI is going to be possible across so many other areas like mental health, which is such a big need, and cardiovascular disease and elsewhere.
Yeah, I mean, part of what makes, MSK so attractive to people is that it can be viewed as acute episodic. And now we know we need to get upstream on those conditions, right? So thinking about a full cycle of care is where we need to go. But employers that know their data, and I'm sure we'll talk later about the unfortunate large number of employers that don't know their data, that actually couldn't tell you how much they spend on a total knee replacement. It's shocking how many that's true for. But the ones that do, MSK always bubbles towards the top of things that are sort of on their minds. Unit cost is one reason, but the other is the inappropriate utilization that's going on in joint and spine surgery, particularly, where these are often elective procedures. And some of the best and most innovative employers, what bothers them the most is the offense, almost the moral offense, of surgery being done on people that really don't need it. And so this is where I would say high quality centers of excellence coupled with point solutions that work in MSK can really work well for these conditions. Lisa Woods from Walmart and I published in HBR about 4 or 5 years ago now, a 5-part series on Walmart's experience, our experience, in MSK. And what we saw, people probably know this number, and this article is where the number came from. 50% of the people recommended for spine surgery in their home markets are found to not need surgery when they come to one of the centers of excellence. And that number is 30% in joint. And these are shocking statistics when you think about it, that probably up to 50% of the spine surgery going on out there is less indicated than it should be. So, to get back to your question, when I think about, is this ripe for intervention? Absolutely. And I think it's narrow networks that are really about quality, not just cost. Great point solutions that work well for the condition. Folks like Vori and so many others that are doing this kind of work well, I think are important. And getting upstream. Now, you asked about behavioral health, and I would say when done right, I think it's amenable to this type of approach, and would say also that behavioral health is not just behavioral health when you think about the expense related to it. So the troubles with social determinants of health that come with behavioral health, and then the lifestyle choices like drug abuse, smoking, etc., pervade into all other forms of care and disease. And so many of these other conditions we need to get upstream on. So behavioral health is important in and of itself, and in the way it then causes worsening of almost every other condition we'll discuss today.
Yeah, John, just to add on to that, and for an employer, those behavioral health issues affect presenteeism, they affect people showing up at work. There's all of those additional costs to an employer if they're not helping people manage that behavioral health issue that they're facing. So,
yeah.
I think that's a really important point that Ellen and I have talked about a lot recently, which is, this question of ROI, how do you define it? And if the point is to save money, I think that is definitely one important goal for any self-insured employer. But you might be looking at different kinds of value. Chris's point about presenteeism, I think that's a really important one, or just employee satisfaction in general. But all these things can be very tied up in the macroeconomic picture. If you have very low levels of unemployment and a lot of just desire to hire a certain kind of talent and competition for that talent, you tend to see more of those benefits that really just lend themselves to employee satisfaction. If that changes, I have these big questions circling around, does it become more about just saving money? Ellen, what do you think is the macro right now in this time that we're living in of just high uncertainty, and what are employers looking for when it comes to ROI?
Yeah, it's interesting. We did another survey back in May on well-being specifically and employer strategies related to well-being. And at the time we were fielding that survey, we were uncertain what we would hear, with the macroeconomic environment. Would employers reconsider investments in well-being that some may consider to be less of a priority? And we saw the exact opposite. We saw that employers were maintaining, if not expanding, their level of investment in broader well-being programs, inclusive of mental health, financial well-being, leave, time away, job satisfaction, physical, you name it. So all dimensions of well-being were poised to maintain, if not expand, because of the macroeconomic environment. And I think that shows that employers do, for the most part, view investments in workforce health and well-being as critical to addressing cost. If they don't invest in mental and behavioral health, if they don't invest in prevention, if they don't help people with financial well-being at a time when the economy is the way it has been, they're going to see a spiraling of their overall healthcare cost. And so they see it as being directly related, and even more important when we're in an environment such as the one that we've been in.
I'm going to ask you another question on that. What has been the general attitude of late or perception of late of point solutions? Are you seeing a desire to kind of cut bait? I've definitely talked to employers who have said, I have 5 now in diabetes. I thought I had bought 1, but now all these point solutions have expanded to not be point solutions and more disease management companies. And so you end up with a lot of overlap. So I certainly have seen, some employers mention that. What have you heard? Are there any areas that you see as real needs, problems to be solved, where there aren't kind of multiple solutions, or do you think it's kind of already fairly saturated, and at this point it's really going to be a winnowing down to the few that, really are getting the job done?
There's a lot in that question. I would
Yeah.
say employers overall are being incredibly discerning of all of their vendor partners. Of course, point solutions are a category within that, as well as health plans, PBMs, and other partners. So employers are taking a much heightened view of those partnerships, ensuring that those partners are delivering, providing data to substantiate whether they're delivering, et cetera. Within the point solution space, we have, for years now been talking about a need for moderation, rationalization. There are many, many players in, certain clinical areas that are doing a wonderful job, and others that are perhaps a little bit more questionable or can't validate their proof points with data. And so in this high cost environment, and where people are getting sicker, chronic diseases aren't getting better, and patient experience is still suffering, employers have to buckle down and partner with the ones that are getting the job done, and hopefully are going to be best positioned to improve outcomes, improve costs, and improve experience. There are some, as you mentioned, that have done a nice job of integrating and expanding their capabilities, and those are poised well. And we've seen that they are, maintaining market share, if not expanding it. There are others who have gone out of business. In certain solution areas, we'll continue to see some of that moderation happen. There are emerging areas, though, that probably have not been fully addressed. Autoimmune is one that we call out in our most recent survey as a condition that is anticipated to have a lot increased utilization and cost in the years ahead, for which there are just a couple of solutions right now and have probably been underserved in terms of the market focus in autoimmune. So that's one that we're watching and where we think there's a lot of opportunity. Behavioral health has been mentioned quite a bit, certainly for very good reason. It has been a priority, needs to remain a priority, but it's also a category where there are an inordinate number of vendors. And when you think about an employer and an employee trying to navigate all of those vendors for perhaps a substance use disorder issue, a youth behavioral health issue, another type of issue. There are lots of subclinical areas within behavioral health and a lot of different point solutions that are serving very precisely a specific area in behavioral health. That's a category that's in need of some integration and some rationalization, as an example.
I love those 2 examples. Chris, I might kind of throw the same question to you, just on if you see any areas of need, and then also a bigger kind of question as well with how employers have evolved their thinking around just being able to pass through claims and see what is actually driving cost, because that was an issue back in the day with some of the early point solutions, that if you want a top 5 cost driver like an MSK or oncology, then you weren't really a priority. But with employers getting very sophisticated, a lot of them now have their own data warehouse. Curious if you've seen that manifest in maybe an openness to things that maybe are number 10 or number 15, but there's literally nothing to serve those members, and it still could be a big potential area of cost savings.
Yeah, absolutely. I see employers really looking to a whole breadth of solutions that they could bring to their population based on really specific needs, and those needs that really drive out a big part of their cost. So I do think they are getting more focused on even smaller and smaller specialties. And so I think that's an important strategy for employers. At the end of the day, though, I think those employers are dealing with a fixed budget. And the reality is, if they're paying on a PEPM basis for these solutions, they've got to be really thoughtful about the trades they make. And that fixed budget is forcing those trades to happen. Now, you mentioned more innovative billing models. People are now taking what were specialty solutions that were PEPM based, and they're billing them through as a medical claim, and they're hitting the underlying healthcare cost rather than hitting their underlying benefits budget. And I think that's helping to bring more point solutions into the mix for an employer and enabling them to serve more specialties by billing that through as a medical claim and making it a part of the overall healthcare provision. So I think employers are using a lot of different strategies. Last thing I'll say is I do believe that data analytics and informatics is really critical to their making really good decisions. And so you mentioned data warehouses. Employers are using data warehouses. They're using data experts and specialty firms in that space to go target the most important elements of what's a cost driver and go address that. It could be something as simple as, hey, people in Seattle are using, emergency care at a much higher rate than people in the rest of the country. Let's go in and do an intervention from a communications perspective to do that. Or it could be related to very specialty kinds of chronic conditions or other conditions that they need to manage using specialty providers. That kind of deep analytics is really critical to driving better outcomes from my perspective, and helps an employer really understand their employee base a lot more intimately.
That's a great point, Chris, and I'm seeing some thumbs up in the chat. And speaking of the chat, guys, I'm going to come to some of the questions in the next few minutes. I'll ask a few more of my own, and then I'll drop in and ask some from the chat. So please keep them coming. But you said an important word, Chris, which is communications. And I have not seen too many super innovative strategies when it comes to communications of benefits from employers. I had the kind of random encounter with somebody that was on the benefits team at TikTok, the company that owns them, ByteDance, and I flagged them and I was like, please do TikTok videos about your own benefits. Like, you're literally the company that should do that. And we talked about it for a while. And I think, we often say, oh, HIPAA, or like, there are reasons why we can't do these things. But there certainly is a potential to just even speak about things like prevention, having somebody like Vin come in who speaks about prevention all day long and address employees in channels that they will actually tune into, including TikTok, if it's still a company that exists months from now. But you guys get where I'm going with this, like mail campaigns, like, really old school tactics still tend to be the norm. Vin, this is a topic you care about deeply. How can we just get some creativity and experimentation happening within the employer channel?
Yeah, it's a great tee up. I loved all the comments up to now. I wanted to touch on a few things that Ellen and Chris just mentioned on point solutions, but to get to your point, I'll try to just lump it together. In my time at Amazon, we experimented with a range of things, both traditional methods to communicate and more novel means. And it was tough to do at a place like Amazon, especially in the middle of the pandemic. But we would do on-site town halls. We'd bring the internal communications team on site with us. And once we felt like people actually wanted to hear what we were doing, which was try to understand in places with our largest fulfillment center footprint, like Fresno, outside of Reno, multiple places in the southeast. We would hear that people had questions about CGMs, they had questions about the COVID vaccine, and build content, but that was could speak to those issues that could hopefully then also educate not just on the issue themselves, like what is a CGM, when is it important, but then point to a vendor solution that Amazon Employee Benefits would contract with, to heighten awareness that, there's actually something you should be taking advantage of, because no one was really taking advantage of it. And what we found was, in these sort of small scale town halls that we would host in these large fulfillment centers, that it became so successful that we started doing a train the trainer model, where managers of teams would come and try to understand the issue themselves, say, what is a CGM, and then be able to speak, armed with some content that we would provide about that issue with their teams. And so it was the opposite of dashboards and mailers about open enrollment. It was direct to the people, and internal communications would come, film some of these authentic interactions, scale it on the Amazon A to Z app, which was, employee facing for 1.5 million employees. And, we would look at metrics afterwards, not just to, so we weren't just making ourselves feel good that, oh, we did something, made us feel good in real time, but we had no quantitative data to back up that maybe there was a difference. But we would look at adoption rates of, a specific vendor that we were trying to heighten awareness on because it was related to the topic in question, or uptake of the COVID vaccine. And we always felt like there was both qualitative and quantitative signals that this was something that people really appreciated, that in-person engagement. I'll go back real quick to something on point solutions, which I think is related to communications. I personally feel, I've spent most of my time in the point solution world, medical devices for chronic disease. And I just, from what I've seen in the United States versus what I've seen from a regulatory standpoint in the rest of the world, I personally think we let perfect be the enemy of the good when it comes to what we allow employees and patients across the country to experience. And it has to be perfect here. And that's the bar set by the FDA. And I know that's maybe beyond the scope of this conversation, but I do think if we communicate on the value proposition of a screening tool, like a biometric scan that is really advanced over time. Now you can scan yourself on an iPhone or smartphone and get a pretty darn good read of your blood pressure, heart rate, respiratory rate, and people love the experience. That technology, though, Chrissy, isn't available in the United States outside of an IRB. In places like Israel, South Korea, Switzerland, it is running rampant through a subscription model for employers, where it is being messaged to these employers and then ultimately to those employees that here's a really interesting, engaging tool. It's right about 88% of the time for detection of high blood pressure. So it's not perfect, but we can message on that, and we can message on the limitations of these innovations. And I think move the field forward to say that let's not let perfect be the enemy of the good, and let's launch and learn. But we need to be able to take some strategic risk. And not doing so here in the US, I think we limit some of these tools that can enhance the success of a point solution, and can enhance the whole engagement conundrum that Chris was talking about earlier. We get in our way too much, in my opinion.
Yeah, it kind of brings up an interesting point around just paternalism as well, that we sometimes assume that, if it's not perfect, that patients will misunderstand things or be led down the wrong kind of path. And I think we don't give patients enough credit where it's due. And I think with the right communication around the risks, I think people can generally understand things. John, because, I think Vin has mentioned a lot of these lower cost things that we're not doing. I want to just ask you quickly about some of the higher cost things that are coming down the pike for employers. A lot of that is cell and gene therapies, and some of these new treatments are pretty incredible because they can be curative, and a lot of these new treatments are also related to children. And yet, price tags can be higher than $1 million to $3 million in some cases. And it's related to, in that case, dependence oftentimes. And so I'm starting to see brokers really talk about this. I'm starting to see employers say, oh my gosh, we got hit with the first kind of claims. It's really only related to 1, 2, 3 people, but it's starting to happen. And so I'm curious if you have any thoughts on just that incoming wave of potentially very expensive cost that employers are facing. Do you think they will just essentially tap out and say, we don't cover this stuff? Or will we see centers of excellence type models, related to this area as well, or new creative approaches to insurance? How do you see this going?
Yeah, it's a great question, because we as a society, we've moved from 100 years of small molecules that are inexpensive treating large numbers of patients to now we have large molecules that are very expensive, treating small numbers of patients. And then you add in GLP-1s, large molecules treating large numbers of patients, and then it gets even worse. But here we're talking about large molecules, very expensive, small numbers of patients. And there are some things cropping up to think about this a little bit smarter and better. The first is, and it's probably news to people that don't know this space well, because you would think, oh, if I have this devastating disease, whether or not I should get this treatment is pretty clear. It turns out it's not always. Indications are important in this area. So making sure you're working with clinical partners that know these things well is very, very important in cell and gene therapy. And I don't have any connection to this company, but companies are springing up like RxCure, where we're talking to them in detail, and Ellen's probably familiar, and others have met. It's Will Schrank and others that are working on this to bring together groups of employers to share risk around cell and gene therapy together and say, okay, we're going to look at this together and approach this together, both from an indication standpoint and pricing standpoint. And where this eventually gets to is then leverage on manufacturers, here, of course, too. But indications really being a key piece. Of course, with somebody like Will attached to it, it's going to be real smart and real good. And I've seen that to be so far. So check that out and others like it if this is an area that is interesting to you. The other
Yeah.
technology folks probably saw, places can now, large systems can make cell and gene therapy on site. So we're starting to see places like your Geisingers and others saying we can work locally to make this cell and gene therapy and shave 3
So
weeks off of.
that's where I thought the COE model was interesting.
Yes. No, yeah, I think we're going to see increasing amounts of that now that the technology exists for somebody like a Geisinger to make the cell and gene therapy, where there may be contracting directly between the employer and the healthcare system to say, hey, we can do this. Yep.
Just going to chime in on this. Will and what he is building is really impressive. They've actually just renamed themselves. They're now called Aradigm.
Thank you.
Just launched and have changed their name. But really impressive to keep an eye on them. And I do agree with the point on the centers of excellence in this space. The slight pushback I would give is the small population that these drugs are applicable for. To date, that has largely been the case for things like SMA, children, et cetera. The pipeline of cell and gene therapies is massive, and it is massive for much broader swaths of the population. So that is one of the things that is certainly a cost concern today, but will be even a more alarming consideration in the future. I've not heard of an employer, just anecdotally, we've not surveyed on this, that is considering not covering these. For the patient populations to date that need them, they need them. It's certainly in the case of SMA, child, it's a therapy that potentially is curative. Very few employers would say no to that. So their challenge is not a clinical one, it is a financial one. And they are therefore looking at all these alternative models that John just articulated around, the Aradigms or other models similar to that. And then, of course, steering towards quality and a center of excellence for those patients that do need to be on these therapies.
And for those that don't, that know this area a little bit or related areas, the stop loss premium piece attached to this can be really important. And so if you get smarter, better, you could talk about shaving just little bits of points off of stop loss premium, which could make a big difference for some employers where this really matters. And the other one, I've mentioned this to Will and others, and I don't think this exists, but I think someone should think about this if they're not out there doing it, is a Klarna-like experience, sort of like a way for health systems, or sorry, employers to finance. Because, for some of the employers we've talked about today, actually cell and gene therapy is not even high on their problem list right now, because some of these employers we mentioned today spend $15 million a day on healthcare per day. And so a $1 million expense, while not something they're loving, is not actually moving the needle for them when it happens twice a year. But for some employers, medium and smaller, it could be devastating, depending on how it's approached. So the idea of a financing approach around this, I think, is an interesting Gen 2 for folks like Paradigm.
I love this
John,
free startup idea that we're now
John, you
getting.
mentioned this.
Thank you.
You mentioned the stop loss, and the stop loss for a mid-sized employer, that's becoming a real tangible line item for them at this point. Because with cell and gene therapy and other really high cost claimant conditions, that stop loss insurance is actually rising at a rate that I think exceeds the 9% that Ellen mentioned earlier. And so, some of those things, again, as employers wrestle with the entire spectrum of costs that they're facing, stop loss is one of the areas I think they see increasing at a very significant rate.
I'm going to shift a little bit to the questions in the chat. I see one from John Butler on the topic of the moment. Ellen's about to smile because it's ICHRA. So definitely have to talk about that in the context of cost. John asks whether or not we will see kind of more traction around ICHRA. I think there are reasons now that jumbo employers probably would not adopt it, that we could go into, but it is something that is being talked about more and more. So I'll pick on Ellen first, but Chris, I think the question was also directed at you, so feel free to chime in. Just what folks are seeing with ICHRA now in the market today.
Chrissy knows my thoughts on this. We've chatted before. Certainly ICHRAs are an area to watch. I think for some of those small and mid-sized companies, as were just mentioned, their backs might really be up against a wall from a cost perspective. And for them, ICHRA may be a viable path. For most employers, though, certainly larger employers, even many mid-sized employers, those who operate in multiple states, those who have long invested in broader well-being programs, an ICHRA would be a substantial departure philosophically and strategically from their programs. And also, an ICHRA is really a financial transfer of the insurance benefit. It does nothing to address underlying population health, underlying delivery system challenges, et cetera. So my concern is that an ICHRA, while perhaps could be a near-term, quote, cost savings, it could actually lead to just the same downstream costs that we've been talking about if we are not also addressing the population health issues and fundamental delivery system issues. So certainly not to be dismissive of them. They will be viable for some employers. I do not see them becoming mainstream for the vast majority of employers.
Yeah, I would agree with Ellen on that. I will say the cost increases are prompting a greater movement to change and creativity and being innovative by employers. I think they are thinking differently than they have. Somebody asked a question about reference-based pricing. I think reference-based pricing, similarly, it's a great solution for some employers. And just in full transparency, we do reference-based pricing for a large number of clients. That is a great solution for some employers, and it's becoming a great solution for more employers as they face these cost increases. And so whether it's that or dynamic copay or ICHRAs, the actual plan design elements for employers, they're getting more creative about those plan design elements as they're facing these cost pressures. So it's not just, specialty. It's not just whether or not we have digital therapeutics that we deploy. They're playing with all elements of plan design as well as the provision of services to figure out how to lower the overall cost increases. The last thing I'll say on it, I think there's also kind of a lost art of care management and doing care management really well, helping direct care pathways with individuals to get them to the right site of care, the right quality of care. Those things really have a tangible and significant impact on costs. And so care management approaches that are a bit more engaged and invasive to help people and help direct their pathways to the right site of care, those really make a difference as well. So I think employers are playing with all levers to try and address the cost and quality issues across their workforce.
Another great question just came through from Ryan Hayden, and I'm going to throw this to the two doctors in the group, John and Ben. Ben, maybe we start with you. Any thoughts on just the issue of rural employees versus urban, especially with very low levels of access to a pharmacy, nowhere near a center of excellence, health system, very potentially some literacy related, maybe communication challenges if it's multiple languages being spoken. Thoughts on that and whether or not you've seen employers doing anything innovative there. And of course, would love to also hear from John on this.
Yeah, I challenge the notion. I think we overestimate how much digital natives or sort of unfamiliarity with digital tools exists in the United States because I think Pew had it that 90% of people own a smartphone, and so my view is we underestimate what patients rural, urban, exurban can do. And I feel really strongly about this. And I'm biased having represented Amazon Pharmacy and seeing that business grow, but I don't think that's a business meant for Midtown Manhattan and coastal or big urban centers and coastal places. No, that's meant and I think uniquely a successful model and business for any community and because it funnels into something that they use, which is a smartphone, and that's all you really need. I do think, Chrissy, to your prompt here, how do we communicate on it? Something like that. It doesn't have to be Amazon Pharmacy. There's many digital pharmacies out there. If people need a different way to access it because they don't have a brick and mortar nearby, I think the figure is 1 in 10 scripts are filled via mail order. 9 in 10 are still picked up in a retail environment. So how much of that is habituated versus people just don't know it exists? I'm not totally sure, but there is a better way to experience the pharmacy experience than historically we've seen. And we know that mail order is better for adherence. It's more convenient. People get 13 hours of their life back. I tend to think that most people just don't know it's an option. They don't know to ask for it. Their clinician may not send it to a mail order option because that's not what they're habituated to do because there's a pharmacy on file. So getting over those reflexes to me is the issue versus digital illiteracy because I think more people are literate and quite facile with these tools than I think, give credit.
Yeah, and John, I'm gonna throw this one to you, but maybe with a slight, just to extend the question a little bit. Ellen and I spent some time recently at a conference where one of the big COE companies that was hosting, they kind of presented some of the interesting data they had, and it looked like people in rural areas were actually willing to travel quite great distances to see a really good to go to a really good health system, whereas people in Manhattan will basically go nowhere. You have to make it like within 5 minutes walking distance or they will not go. And so they found some like fascinating, I think, regional differences. And so I'm curious for your thoughts on that, as this is a space you know very well, and just anything broader on this kind of question of how to reach people in rural areas.
Yeah, we found in the work with Walmart over a decade now that the ability to really innovate for people in rural areas is quite high when you make it a priority. And of course, for Walmart, that always was a priority and will always continue to be a priority from my perspective. And we do. I still practice as a neurosurgeon, by the way. I operate 1 day a week, and 50% of the people I operate on come in from out of state and almost always rural areas, as part of that destination program. And a lot of times, Chrissy, it's the first time they've ever been on a plane. They love the benefit, the people that take it, and it's many that take it. They do. Because it's a concierge white glove service that feels like it's designed for an executive. And here's somebody that stands on concrete, working really hard to help their local community all day, gets this wonderful benefit. So yes, to your question, do people in rural areas embrace this? They do. And I want to call out one of the least told stories right now in healthcare is how rural and people and the collision of them over the next 5 years, I think, is going to be one of the most important stories in healthcare. Why? This year is the first year that the construction of data centers in cost will exceed the construction of all other forms of construction commercially in the United States. And almost all of these data centers are going into rural areas. And the large employers and others building these data centers are contending with, what does this mean for getting healthcare in rural areas? So oftentimes they're partnering with really innovative healthcare systems that may know those areas where the data center is going. But then the things I think any of us on this call would say, remote patient monitoring, a real strength for the delivery of rural care and something to think about. Mail order pharmacy was already covered, very, very important. And I think, extremely useful. And I think even those on this call, if you have a mail order pharmacy option, consider it. I think once you get into it, you're going to find that it's real valuable. And then this sounds a little bit on the edge, but don't sleep on satellite and drone-based services that are increasingly becoming important in healthcare delivery, certainly in drop-off of urgent supplies, drop-off of even non-urgent supplies. This is becoming increasingly part of it. But I think we're going to see a lot more media coverage in the next five to 6 months about why rural matters with respect to the data center growth.
I love that, and that drones are part of this discussion. It's fascinating to think of what's to come. In our remaining minutes, and it's been a fantastic discussion, Alan, I'd love just some thoughts from you on, really the topic at hand, which is rising costs. And to me, sometimes for an employer, it's like being a frog in a pot of boiling water. Apologies for the horrible analogy, but at what point do they jump out of the pot or die? Like, it is getting worse every single year. And employers in other, this is not something that they have to do. In other countries, they don't do healthcare. And so, how bad does it have to get before you see employers just raising their hands and saying, this is not our problem? And I am seeing some of that dialogue with employers, especially ones that have businesses that may be much lower margin, where, that swing of a few $1,000,000 is actually extremely meaningful. And, healthcare is crushing to these employers. And so, as you look at the surveys, you do these surveys year after year, what is your thinking right now? Just like, how bad does it have to get before we see a real major evolution in the space versus incremental progress?
We've asked the question, and we don't see any employers considering exiting entirely as a strategy in the near term, for a lot of different reasons. I think the employment dynamic here in the United States, benefits and healthcare are a huge part of that total rewards equation that employees evaluate. So if one employer were to get out, they would be instantly at a disadvantage. You would almost need all employers to get out together to neutralize that being an employment consideration. So
they're like many frogs in many pots of
yes,
boiling
they all need to
water.
jump out together. So that, there's just a workforce dynamic and an employee expectation of their employer dynamic in this country that is different from others. There is also, I think, at a macro healthcare economics perspective, the commercial, aka employer market, subsidizes every other healthcare market in this country. Employers pay 200% more to 600% more than Medicare rates, right? And so if employers, and you did not have that commercial subsidy happening, what would happen with just the fundamental economics of all the other healthcare markets in this country? So I do think we've got to solve for that as an industry in this country. If more employers were to get out, I think that creates some real financial viability concerns elsewhere that would need to be solved for. And back to the, population health concerns, employers, and Vin knows this, employers have become a much greater trusted messenger around public health, messages that need to be communicated to the workforce on a variety of issues. And they are viewed as more trusted than some other institutions, and employers are looking for them for clarity on, should I get a vaccine or not? What screenings do I need? The age requirements and recommendations keep changing on me, right? So I think there are just other macro level economic and public health issues that employers are playing a vital role in addressing. I think if there were a better path, a more sustainable path, you would have some employers who would seriously consider, maybe this isn't the role that they should be in. Maybe they should get back to their core business of whatever industry that they're in. But we don't have a better, viable, sustainable path out at this point.
I think you would need big policy changes. Vin, your thoughts?
Oh, I just want to quickly plus one Ellen's point there. we're having this discussion on the backdrop of a significant hearing with the HHS secretary right now. Not to get into the weeds on that, but we just had a question on rural healthcare, and there's a different reality in how you have to communicate in an urban setting in many parts of the country than in a rural setting. And that directly impacts what employers then have to contend with when it comes to engagement, participating in screenings and in vaccinations. And I think we have to directly tackle that because, none of these other things, in my opinion, matter as much if we can't solve the communication trust issue, which is only getting worse. But Ellen's point there is spot on. It's going to have to be through employers leaning into creative strategies because they're trusted.
We have about 5 minutes left, and I promised everybody that we would wrap on time. I would love to do a quick round robin, just to finish up the conversation on just one thing that you each on the panel are most excited about spending time. Just like, what are you reading about on Reddit if you want to go into a deep rabbit hole at 1 a.m. and you can't sleep? Like, tell us one thing that excites you the most in this kind of sphere of the world of employer that you think people tuning in should know about, and just keep it short and sweet if you can. I'll start with Chris.
Yeah, I don't know if it's something I'm reading right now, but I'm in the midst of trying to figure out the weight loss environment and whether or not, the weight loss environment that digital therapies and other solutions are making available, how effective it is in enabling people to develop better habits. And I'm kind of diving in personally into that to try and, engage in it and experience it and see the impact that it has on the way that I think about my own diet, my own exercise, etc. And that's been a real learning for me, just to try and understand, the struggle that it is, and whether or not we're really giving people the tools that they need to understand and manage their weight loss more effectively. And so it's been an interesting journey over the last several months for me.
Yeah, I'm likewise also fascinated by that topic. John, what are you looking at Reddit at 1 a.m.?
Yeah, I love this idea of some employers increasingly now getting involved in what are people doing for health span and longevity? What's going to stick there? I mean, that feels far away for the employer, but it's not, right? And you and I actually wrote about this today in Second Opinion. So take a look, folks that are interested. The things that our doctors are doing are going to be things that the populace is going to be more and more interested in the next year or two. And my final message would be to say, for employers out there who may have operational and strategic and results concerns about making change, I want to say this to you. Your operational concerns can be real and it can be hard, but there's folks that can help. But if you or your boards have strategic concerns, they're probably not real. And I want you to get ready to release those into the air like a Japanese lantern and let it fly away. Because what I would say to you is, me, Ellen, Chris, others on the call, we've done this ROI work for you. We've done the success work. We've written about it. It's proven. There are ways to do this better. So yeah, operational concerns real. Let folks help you like Chris and others. But if your concerns are strategy and results, it's time to let those go, in my view.
I love that hot take. Ellen, what are you thinking about right now? What's top of mind?
I'm going to build on what John just said, and mine is this, this specter of disruption, and it has long been something that many employers have avoided. The last thing they want to do is do something that is viewed as, quote, disruptive to their workforce. But I would argue that the current state is highly disruptive to their workforce and to their businesses. And so we have to disrupt, and disruption is a path to better. And doing nothing and staying in the status quo environment is highly disruptive.
I think we finally got that something has to change. And we just don't know quite yet what that will be, but lots of just fascinating stuff like floating around in the ether, which is what makes it interesting. Vin, how about you? Close us out.
I spent a lot of time thinking about, just given my background, direct to consumer businesses in healthcare, whether it's wearables, whether it's teletriage, mail order pharmacy. A lot of this stuff seems to exist outside the employer channel, and how employers start to think about what their role is when it comes to these direct-to-consumer offerings, whether it's, say, it's Lilly Direct, Pfizer for All from the manufacturer standpoint. Big tech is offering any number of things from wearables to these new offerings. It feels siloed right now, and it feels like employees are just off doing their thing. Maybe they use an HSA benefit, but not often not. What is their role there, and is there an enterprise play for some of these direct-to-consumer offerings?
That is brilliant. I think for me, it's probably some of the cell and gene therapy stuff. So if anybody's working on that, don't hesitate to reach out. And I just wanted to say thank you to this incredible panel. I think we had the right discussion for the moment in time that we're at. And I really appreciate you all joining me for the past hour. Thanks to everybody who tuned in, and to my co-hosts, Personify and Chris. Yeah, just appreciate that you all wanted to elevate this topic. So thanks everybody. We'll do one of these again. And if you have any more questions for each of the group, you can reach out on LinkedIn. I know for a fact they're all responsive. So please do reach out to them. Thanks again.
Thanks, Christy. Nice job.
Okay.
Thanks, everyone else.